I think the focus on preventing readmission has been generally a good thing to help us to focus on a critical issue in the management of acute coronary syndrome and subsequent risk, and that is the transition of care. This is an enormously important area because we generally do a good job now in the hospital in managing acute coronary syndromes. In fact, it's remarkable to see what's happened in the United Kingdom based on the data from the MyNAP registry, where we see that ST elevation myocardial infarction now, something like 90% of patients are getting primary PCI, and 90% of the time it's in a timely way. It's a dramatic turnaround over the past 10 years. So the in-hospital care is excellent. What's not good is the subsequent care. Part of the problem is we don't really measure this. We're not focused on it. The focus on reducing hospital readmission then helps us to really focus on, are we doing a good job with assuring that patients are getting the appropriate instructions, the appropriate teaching, and that we're following up so that we have a linkage between the plan at the time of discharge and what actually happens in the clinic, and then what happens over the next year. Because over that year is a time of particular vulnerability. We've had a lot of focus on ST elevation MI. These are the patients that are getting the primary PCI, that are therefore getting, almost all of them get effective P2Y12 antagonist therapy early on, and they tend to be in, at least for some period of time, in cardiac intensive care units where there's a lot of focus on assuring they're getting the best care. And the non-ST elevation MI in many ways is a more challenging group because these patients tend to be older, have more comorbidities, and maybe are not as intensively treated in the early hours and days of their presentation. And they're the ones, paradoxically, even though the risk in the early hours is highest for the ST elevation MI, the risk over the next year is substantially higher in the non-ST elevation MI. And moreover, ST elevation MI is declining in incidence, whereas non-ST elevation MI continues to be a more common occurrence. Because of more effective prevention measures in the population, and because of the decline in coronary heart disease in general, ST elevation MI seems to be decreasing, whereas non-ST elevation MI, which is more common as patients have more advanced comorbidities and are aging, continues to be a problem with the accumulating risk over many years. And in fact, many patients with non-ST elevation MI have already had an event. So for example, somebody who's had an ST elevation MI, who survived that event, who has progressive vascular disease, then will come back with a non-ST elevation MI. So one of the ways we can reduce the burden of non-ST elevation MI is to more effectively prevent the recurrent events after the initial presentation. So there are some differences in the guidelines from Europe to America for post-ACS care, but they're mostly in the details. I think the guidelines really are quite similar in terms of the general principles, which, as they should be, because the evidence is the same evidence, and it includes assuring that, for example, that patients stay on P2Y12 antagonists for 1 year. That's a good example where we see the adherence to that guideline is unfortunately very poor. There's a big gap there. And it's also true of many of the other medications, even including statin treatment, which is another really important way to reduce long-term risk of patients who come in with acute coronary syndromes. So the differences, I think, in this secondary prevention dimension are relatively modest and are more geared towards the individual agents than they are to the general principles. There continue to be major gaps in the guideline-directed care and how care is actually delivered, including in patients after acute coronary syndromes. And the medications and the treatments that patients receive in the hospital and at time of discharge are really quite good, I think. So the hospital phase has really been successful. But then what happens is, after discharge, the evidence-based treatments to reduce risk of secondary events, the continued use of P2Y12 antagonists, of beta blockers, of ACE inhibitors for patients with lower ejection fraction, of high-intensity statins, of cardiac rehab. For each of these is a rapid drop-off and a major opportunity to improve long-term care based on improving those. And part of the challenge is we don't tend to measure those things. We have very effective ways to measure and feed back performance when the patient's in the hospital. But once the patient leaves the hospital, we're not effectively measuring how we're doing with those elements. And I might just say one of the simple recommendations that we have for that is we have three major evidence-based approaches to improve the transition of care. And those are what we call teach back, call back, come back. These are the three really evidence-based approaches to improving transition of care and adherence. Is this teach back, the idea of bidirectional interchange between a patient, the patient's family or provider, and the healthcare provider. A callback, an early communication with the patient to assure that the medications are reconciled and that there's an early understanding that the patient actually filled the prescriptions. In the United States, only about 10% of the time, patients don't even fill the first prescription. Some hospitals have had a policy where the patient doesn't leave the room in the hospital until they are given the new prescriptions that are provided. But most hospitals aren't doing that. So at least assuring that on this early telephone call that the patient understands and has these medications, and then the comeback, the early hospital visit is something else which has been shown to be an effective way to assure that the communication is effective, that the patient has reinforced messages about adherence. So yeah, I think it has been shown to be effective. Now we do need more work to understand how to best implement some of these interventions. And in fact, we're doing some of those programs. A lot of work is going on to better understand that, including what's the impact on rehospitalization. But we believe that this is an important evidence-based way to reduce rehospitalization as well. Well, the U.S. guidelines are parts of them are applicable to anywhere in the world, like the evidence for which treatments reduce the risk of recurrent cardiovascular events. But other elements may not be applicable. The frequency of follow-up, some of the specific recommendations around transitions of care and providing education materials to patients and families may substantially differ in different healthcare environments. The tools to help physicians follow the guidelines are also very important, and perhaps the most important is the measurement and feedback. You know, we have this mantra in quality improvement that if one doesn't measure it, you can't improve it. And we can very effectively and have improved acute care of acute coronary syndromes through measurement of performance in the hospital. And what's lacking now is that same measurement about 1 month after discharge. Is your patient still on the effective treatment? What proportion of patients have gotten to cardiac rehab? At 1 year, what proportion of patients are still on a P2Y12 antagonist? And I think if healthcare providers had that information, and saw the gap, that it would be a very effective way to motivate people to assure that these tools were being put into place to improve the care. The risk of bleeding is not very well communicated to patients after acute coronary syndrome who are on these treatments. Now, we need to be a little bit careful about that messaging. I think it is important for patients to know that there is a risk of bleeding, that we want to be careful to always talk about risk as something which we want to reduce. This is being implemented in many countries around the world, and I think some examples include the United Kingdom, with primary care being incentivized to assure that patients' blood pressure is being managed, lipids are being managed, diabetes is being managed. The simple, critically important risk factors have been much better managed related to the National Health Service focus on tying reimbursement to that. Some of the Scandinavian countries, Denmark and Sweden, the government has put an enormous focus on having high-quality registries and a focus on improving quality of care. And there, the care is some of the best in the world after acute coronary syndromes. So I think each of us can learn from what other countries has found to be successful in improving secondary prevention. I think examples of where the U.S. and other countries could learn best practices in how to support secondary prevention do include the registries from some of the Scandinavian countries, specifically Sweden and Denmark. The Swedish registry has been remarkable, and Lars Valentin and others have shown this dramatic improvement over a 10-year period from about the late 1990s, 2000 or so, largely related to the fact that all hospitals were systematically collecting data through government-supported programs and focusing on improving quality. And then we have other examples, even, for example, in India. Dennis Xavier and the St. John's Group have done some nice work with using text messaging on cell phones to improve the persistence and adherence to statins, aspirin, blood pressure control for patients after acute coronary syndromes in a trial called the SPREAD trial. And it was in India, but it's not so different from what we all deal with. Patients there, it's a particular challenge to get patients to come back, to travel longer distances to come back and see the physician. So using some of these technologies like cell phones has been quite effective at improving secondary prevention.